وسنبدأ الجلسة الأولى بالمحاضرة التي سيلقيها الدكتور صالح أبومahara، وهي Rotator cuff tears. فليتفضل.
Ladies and gentlemen, it's a great pleasure to share with you some knowledge regarding the rotator cuff tear. This information, it might help you for decision-making process when you are treating a rotator cuff problem. Usually in my practice, daily practice, when I face a rotator cuff tear, I ask myself one question: if I leave this patient alone, what will happen? To answer this question, we have to understand well the natural course of disease. As you know all, it's wear and tear phenomena. It's most common shoulder condition, tear mostly related to aging, no symptomatic large tear healed. If we go back to the history, we start 1788 with Alexander Monroe as described the hole in the ragged edge. We go down with John Smith, Muller, Kodman, Neer, Illman, Graeber, Goutelier, and Tillian Lou, 2003 with double row technique. The question usually we ask when the daily practice, when we face rotator cuff problem, should we repair every tear? No, there is a concept behind that. We have many conditions. We have partial thickness, we have full thickness, we have partial large, we have partial tear. No, there is articular tear partial. Yes, retracted, atrophied, or both atrophied and retractor. There is a many condition. We see it in the rotator cuff problem. Do we fix all? Go and sew, or there is a concept behind it? The concept is the understanding well the natural course of disease. So why, that's the Steffi graph, if you remember, why she doesn't have a rotator cuff problem. Why supraspinatus tear in dominant and non-dominant limb? Why supraspinatus tear not more frequent in the manual than an office worker? This is question has, until now, there is no clear answer. We go back to the anatomy for interrelated muscles, supraspinatus, infraspinatus, teres minor, subscapularis, you know it all. The function, dynamic stabilization, contribute the strength of the arm, 50% of abduction, supraspinatus, couple for stabilizing, and if we have rotator cuff torn, cannot counterbalance the upward pulling of the deltoid and the humerus. So the natural history, do we want actually as a surgeon to change the natural history? I don't think so. Frequency 30%, significant correlation always with age, 45% asymptomatic cuff tear over 60 years, 28% full thickness, 34% degenerative rotator cuff. Tender degenerated increased with age. There is a nice article, the joint side tear rotator cuff, a follow up with the arthrography, show that's 10% healed, 10% decrease in the size, and 80% full thickness tear from Yamanaka Clinical Orthopedic Related Research. Full thickness tear don't heal, but some, but not all of them will progress. Rotator cuff arthropathy 4%, 50% newly symptomatic tear will progress in the size, no tear seems to decrease in the size. 80% of partial tear become full thickness tear in 2 years. Yamaguchi knees orthopedic shoulder course 2006. That means 50% of cases in 4 years it will progress. When we say partial tear, it's like when you flip the coin, 50-50. Asymptomatic tear becomes symptomatic in 10 years time, 50% develop symptomatic, 50% increase in the size, symptom related to the tear size, rotator cuff tear, not only age related, but also bilateral. More than 51% of patients briefly asymptomatic and contralateral symptomatic will develop symptom and non-symptomatic in 2.8 years. Yamaguchi Shoulder Elbow Surgery Journal 2001. How frequent the rotator cuff and the risk factor? The risk clear it with age. If we our age in full thickness tear 40 to 60 years, 4 to 13% full thickness tear. But if you go down with the 80, it's 80%. If we see the partial thickness tear, if we are less than 40 years, 4%. If we are more than 60 years, the partial is 25. It's a very nice article from Tempelhof in the same journal. Predisposing factor, age, the most important. Sex, it's not clear that there is evidence regarding the sex. Hand dominant, also is not clear. Some article supporting there is with the dominant hand, the other find no predilection, not significance. Contralateral shoulder, it's reported that there is contralateral, it's bilateral tear after 60 years of age more than 50%. Yamaguchi in the same GBGS 2006. Smoking is strong relation. Family history is also has a relation. The other thing is, which is very important, the impact of faulty posture on the rotator cuff tear with or without symptom. It's very nice article from Yamamoto shoulder joint surgery showed us the kyphotic lordotic flat back and Sui back has high tendency to have a rotator cuff problem. Trauma, you know it all, it's very strong relation. So that means is 50% of rotator cuff tear progress within 4 years and might become irreparable in 9 years. If you understand the course of the natural history, you will think in every case you see it with the rotator cuff problem. Predictor for tear progression and muscle degeneration related to the pain, related to the large tear size, and is very important when you have disruption of the anterior rotator cable. Illman has classified the tear to bursal side or articular side based on the location and the depth of the tear. The articular side tear result more commonly from intrinsic factor, the bursal side from the intrinsic and extrinsic side. The Millet classified the, you know it all, the tear pattern. We see the crescent, reverse or U-shape or full thickness contractor. The extrinsic mechanism, that's the impingement problem. The intrinsic mechanism, the microfracture, hypovascularity, and the internal impingement when the deep side of supraspinatus muscle and posterior edge of the glenoid impacted together lead to the tear. Clinical situation, you know it all, anterolateral shoulder pain. Night pain is 83%. All the tests is empty can, Hawakin, painful arc, external rotation, drop arm test. All that is sensitive for rotator cuff problem. But when you examine your patient, no test alone is perfect. You have to combine the test to reach the full diagnosis. We see here the imaging. We use the ultrasound and available provide excellent tender visualization on 99 shoulder with rotator cuff disease, comparable sensitivity and specificity of MRI and ultrasound found there is a problem in the ultrasound for detection of the partial thickness tear if we have more than 1 centimeter in size, ionity in the GBS. Compare the preoperative and postoperative ultrasound finding 42, consequently operated patient obtain excellent sensitivity and specificity for full thickness tear 100%, 97% for the ultrasound. The results were more dismal for partial thickness tear with sensitivity is very poor, 46%. Similar report, poor sensitivity, ultrasound and diagnosis of partial thickness tear. MRI provide vital information and outstanding details, not only on rotator cuff tear, exact the location, long head, the bicep, the fatty degeneration, the muscle tendinous junction. Actually, the literature is flooded with studies comparing the two techniques. One in 124 consecutive painful shoulder report similar accuracy of ultrasound and MRI to Fibon joint American. Evaluation of 20 studies with 1,147 shoulder failed to illustrate any significant difference. Lens cohort database. Meta-analysis observed sensitivity and specificity over 90% of full thickness tear with using the ultrasound and MRI, with specificity of partial thickness tear with both modulator was over 90, lower sensitivity 67 to 83 were seen in partial thickness tear, Roy in sport medicine 2015. So less frequency utilization images, including plain radiography, arthrography, computer tomography. Maybe the other colleague in Tunisia, they use it more than us. We came here to non-operative treatment. Rotator cuff tear don't behave the same in different patients. So we give analgesia, we give anti-inflammatory, we give modification of the lifestyle, subacromial injection, whether steroid or PRB. The benefit of non-operative treatment, avoid surgery and potential complication. In follow-up of 19 massive non-operative managing rotator cuff tear show satisfactory shoulder function at least 4 years. In a study by Moon Shoulder Group, 452 patients with atraumatic full thickness tear, significant improvement also in 6 to 12 weeks. A long-term follow-up, 43 rotator cuff tear over 13 years, observed nil or only slight pain in 90% of patients, while 70% of patients had no disturbance of the daily life activity. Poor result with conservative treatment for full thickness tear have been reported. 52% progress in 33 full thickness tear over mean 2 months, demonstrate supraspinatus atrophy in 24% patient. Maman in the bone joint surgery American. In 61 non-operatively treated symptomatic rotator cuff tear at mean 29 months, report increased size is about 50%. Zarfan in the Journal of Sport Medicine 2011. So here we came to the confusing how we choose our patient. Do we choose it as young or choose as old? Non-operative management should be individualized, considering patient expectation, symptom, and response to the previous non-operative treatment. Widely suggest early surgery in patients below 60 years or healthy symptomatic 60 to 70 years old, having increased demand of the activity. Patient older than 70 with low demand can be managed non-operatively. Sorry. Okay. Okay. Always think about the suture material. It's very important. Bioabsorbable anchor over their metallic counterpart over no lasting foreign object. Potential drawback, including unpredictable loss of strength, eyelet rupture, or foreign body reaction. Anchor insertion must be standardized from the 0 to 45 degree. Partial thickness tear can be operated after fair trial of conservative treatment. Repair of non-overheaded and overheaded athletes considered tear more than 30 to 50% and 75%. Excellent post-operative outcome have been reported in data of 16 studies, ranged from 28.7 to 93%. 39 partial thickness tear managed acromioplasty debridement, suturing, follow-up 55 months, revealed satisfactory to excellent result. Excellent healing after arthroscopic conversion of partial thickness tear to full thickness tear. 88 had intact repair 11 months. No significant difference had been reported between articular side tear or partial side tear following the conversion to the full thickness tear. Comparing 105 arthroscopically repaired small, medium, full thickness tear with 64 partial thickness tear demonstrate excellent result. If we see here the appropriate use criteria recommendation from the American Academy of Orthopedic Surgery, they advise as appropriate for a repairable tear if an patient responded conservatively, or appropriate for healthy symptomatic patient failing conservative management. Arthroscopic technique, we have two techniques, whether single row or double row. On 160 patient, revealed significant greater improve in the double row. So even here, the literature is flooded, double row or single row. The advice, if we see the meta-analysis comparing single row with double row, revealed significant higher re-tear rate in the single row, especially in the partial re-tear. Others have found equally improvement outcome after we used single row or we used the double row. Like here, it's fantastic article, Lejgrasso Arthroscopy 2009, show that there is no difference. Significant higher healing has been observed in the double row technique surgery from Grassman 2013. Few studies have criticized the double row and proclaimed the superiority of Dissembler for single row method, recommended no significant difference in clinical outcome, and found the double row technique to be demanding, expensive, and time consuming. Double loaded anchor margin convergent suture provide excellent result with significant improvement in the functional parameter. We use the treble loaded anchor in the single row, show increase the footprint coverage, which is very important when you treat the rotator cuff problem. Knotless self-reinforcing double row and the double row repair have shown higher patient satisfaction and serve as alternative option for managing the rotator cuff problem. So when we face the repairable tear treatment option, we do the debridement, we do tendon transposition, we do muscle transfer, we do biological augmentation, or we came to the end with the inverse reverse shoulder. That's not our subject today. So based on the above discussion and the existing evidence, the suture technique and anchor location should be chosen based on the tissue properties, tear pattern, and dimension and surgeon experience and comfort. Partial thickness tear, whether it's partial site or articular site, do well with the surgery. In full thickness tear, mini open or arthroscopic repair provide comparable outcome with better short-term pain control. The take-home message, think well, all patients are the same, but the indication is different. Usually access repairability well, solid suture and fixation medial to the cable, avoid overtension of your suture, usually medialize your insertion, avoid double row just when you need it, protect your repair and abduction splint. Thank you very much.